Good morning, everyone, and thank you, AIOS, for giving me this opportunity. And with the regards to the chair, I start this postoperative endophthalmitis and update. We all know it's a dreaded complication with 15 to 30% having a grave prognosis on the visual outcome, and it leads to loss of quality of patient's life. Overall endophthalmitis rate, it is 0.265% worldwide. Various factors they play a role: rural patients, diabetes mellitus, blepharitis, ectropion, vitreous loss, and anterior vitrectomy, PCRs, and so on and so forth. Intraocular optic materials and mechanism of insertion, silicone and PMMA, they are compared to have more chances of getting the endophthalmitis cases and chances. Insertion of IOL using a sterile injector is supposed to have a lower rate of endophthalmitis than in IOL insertion with forceps. Unsutured clear corneal incisions, they raise the rate of endophthalmitis postoperatively. A little late installation of topical antibiotics a day after surgery instead of the same day of operation, and use of the older fluoroquinolones, they lead on to increased rate of endophthalmitis. Clinical presentation, we all know, is the visual acuity with pain and redness of the eye, and usually occurring 1 to 2 weeks post-operatively. Prognosis, great advances are there in the management of post-op endophthalmitis. The prognosis is unfavorable, and 20/40, 6/9 or better is the final visual acuity, and nowadays we have a lot of drugs with us. Prognosis is usually compromised by the increased incidence of bacterial resistance. There are various organisms we get across CONA, cons, and Klebsiella pneumonia, enterococci. Propionibacterium acne, we all know, it causes a late chronic course, is there. It's a smoldering kind of endophthalmitis. Candida albicans is seen in 16 to 27% of cases. There are various prophylaxis protocols. Meticulous surgical preparation should be there. Lid hygiene is very important. Copious irrigation by topical antiseptics, we all know povidone iodine plays a great role. And antibiotic prophylaxis protocols and timing, they are important. Preoperative, intraoperative, perioperative, and postoperative. All are very important. Systemic use of intracameral cefuroxime was recommended by a prospective randomized controlled trial by ESCRS, and subconj injection of vanco and ceftazidime can achieve adequate aqueous concentrations to reduce this rate of endophthalmitis. 3 days course of antibiotics, they say, is more effective than a 1 day or 1 hour course, especially with the synergistic effects of povidone iodine. So cefuroxime, it's a second generation cephalosporin, ineffective against methicillin resistant staph aureus cases and enterococci. It has not been approved by the FDA. There's a wide safety margin and it is very well tolerated. So it is used as prophylaxis, and side effects results from accidental intracameral cefuroxime overdoses comprising macular edema, hemorrhagic retinopathy, SRD, and corneal edema. Moxifloxacin, broad spectrum microbial coverage is there, very good diffusion into the anterior chamber. There are very low adverse effects, and use of intracameral moxifloxacin with the overall reduction of endophthalmitis has been seen after cataract removal. There's a very wide safety margin with this moxifloxacin. Vancomycin, it's having weak effect against gram-negative bacteria. However, it works well against other organisms. Recently, intracameral vancomycin has been greatly recommended by the American Society of Cataract and Refractive Surgery for endophthalmitis prophylaxis during cataract surgery. It has a wide safety margin. There is a bilateral ischemic retinal vasculitis and hemorrhagic occlusive retinal vasculitis being reported in the form of delayed onset painless vision loss following cataract surgeries with this. Antibiotic of choice for both prophylaxis and therapeutic intracameral injections for endophthalmitis are seen in many parts of the world with 100% sensitivity for gram-positive bacteria. Corticosteroid therapy, it reduces the immune inflammatory response, reduces the anterior segment inflammation, except in cases of suspected fungal infection. Installation of topical prednisolone acetate 1% for several days up to several weeks is very, very effective. Subconj injection of 4 milligrams dexamethasone is administered at the time of initial intravitreal antibiotic therapy. Oral corticosteroids, prednisolone 30 milligrams twice daily for 5 to 10 days is recommended starting from day 1. However, the timing, dosing, and route of steroid administration are controversial and highly dependent on the organism responsible. Diagnosis, it depends on clinical suspicion. We have to rule out the makers task, we know, and PCR test, gram staining culture, they need to be done. B scan is also done and is diagnostic in 30%. There are various differences between TAS and endophthalmitis, we all know. When it is detected, onset is 12 to 24 hours in cases of TAS, and for endophthalmitis, more than 24 hours. Corneal limbus to limbus edema is there in cases of TAS, and in pupil is non-reactive, IOP is high, and ultrasound is anechoic in TAS. In endophthalmitis, we all know there is a reactive pupil initially before the exudates are formed, and then IOP can be from normal to low, and exudates are present in the vitreous close to the retina. So need a close follow-up. Microbiology profile can be done, and vitreous biopsy can be done, and without turning on the infusion, we should take 0.3 to 0.5 ml of sample in a gentle manual aspiration form. Vitreous tap, it is done in vitrectomized eyes in recurrent and non-resolving cases. Avoided in phakic and non-vitrectomized eyes due to the risk of inducing vitreous traction and subsequent RD. Management, systemic antibiotics, they have a controversial role. Systemic fluoroquinolones, they have a faster resolution of hypopyon. There's a decreased need for repeat intravitreal antibiotics in patients with acute post-op endophthalmitis because these drugs cross the blood aqueous ocular barrier. Control of massive bacterial post-op endophthalmitis is the simultaneous intravitreal injection of unpreserved dexamethasone and broad-spectrum antibiotics combination is recommended. Vancomycin ceftazidime is injected intravitreally as first-line treatment, and vancomycin is used as second line. Repeat injections of vanco or ceftazidime may be indicated after 48 hours. The choice of antibiotic for repeat intravitreal injection is based on culture result. In cases of fulminant refractory acute post-op endophthalmitis with the rapidly worsening visual acuity, we all know complete vitrectomy is the choice. And delayed onset post-op endophthalmitis, it is difficult to treat because of its delayed diagnosis. Partial capsulectomy is done associated with the injection of intraocular antibiotics, and in only 50% of cases resolution is seen. There can be 70 to 90% of cases completely treated with total capsulectomy and IOL exchange or removal because the organism, we all know, they get sequestered in the capsule. Intravitreal antibiotic injections, IOL extraction and vitrectomy, they remain the best treatment options. Conclusion, because this was all the updated data which I had given, so I conclude by saying that evaluate for any potential risk factors. 5% povidone iodine is the antiseptic agent of choice. Meticulous intracameral antibiotics in a sterile manner at the end of cataract operation is important. We talk of cataract because all endophthalmitis literature, it is revolving around cataract surgeries. It is for all the surgeries basically. Early follow-up after cataract surgery is required. Ensure patient's compliance on post-surgery medication. Precautions to reduce the serious complications caused by late diagnosis and treatment of post-op endophthalmitis. Thank you.
Thank you, Dr. Manisha. Do we have Dr. Aman Kumar? Okay. He has got a similar related topic, emergency room endophthalmitis.
We had a cluster endophthalmitis cases 2 years back in our department.
Okay.
And not from our institute, but they were coming from all around. And we operated upon about 70 vitrectomies were done by 2 operating surgeons in a week's time, with handling all the administration part and all the medications and all. So it was very well managed cluster endophthalmitis. I think the widest, largest in the world.
Madam, just I want to ask, which cases you preferred for injection and which cases you opt for surgery? Whatever criteria was laid down by literature, same you
if it is a early presentation, okay. If it is a first 48 hours, we can always go for injections. And if it is coming with the late presentation, generally in our setup, like I'm working in postgraduate institute, so people, they generally send these patients very late after trying all the medications. 2 to 3 days later, obviously we need surgeries. Vitrectomies are required.
What were the outcome in your this cluster of the endophthalmitis?
They were very well managed, but because the presentation was late, so we lost few eyes.
Okay.
They came for follow-up. They came for
overall
follow-up for a
outcome,
long.
how much percentage you come out with good outcome?
I would say that was about 30 to 40%,
Okay.
not more than that. Yeah, Pseudomonas was there. Yeah. There was something wrong with the viscoelastics. Not to say more about it.
So,
but
madam,
it
what
was-
is your experience in a private practice or in a small setup? What things should, or in camps also, what things should be taken care of? What is your perspective?
I think an initial management of endophthalmitis is very, very important. One should know how to detect, early diagnosis, and early referral.
Okay.
Should not be waiting, and from peripheral centers they should be sent as early as possible. That is the only one thing which can help us manage. And if something goes wrong in the peripheral centers, somebody can come along with the patient and tell the history and the whereabouts. That is important.
Yeah, thank you, ma'am.
Next person I think is speaking on the operative room endophthalmitis, and those precautions are to be taken anywhere, be it a peripheral center or major center.